Assalamu alaikum, Bismillahirrahmanirrahim. Good afternoon to all. I welcome you all to the weekly webinar session organized by Oncology Club. This time our session name is Breast Cancer Management, What We Need to Know. So today our topic is Principle of Various Guidelines and Recommendation in Breast Cancer. And our faculty is Dr. Irfan Ahmed, who is a consultant radiation oncology, thoracic and breast division of Rajiv Gandhi Cancer Institute and Research Center in Delhi. And as per custom, we always start with few words from our president and patron, Professor M.A. Hai. I would like to request our president, Professor M.A. Hai, sir, to say a few words so that we can start the session. Professor Hai, sir. Sir.
Thank you, Dr. Kamal. I'm happy that we are doing a breast cancer testing. I think but thanks to Dr. Irfan as well. Data will start immediately.
So can you hear me, Irfan? Dr. Irfan, you mentioned that you cannot hear us. Can you hear me? Dr. Irfan, we cannot also hear you.
Has he joined?
Yeah, he is there, sir.
Okay. There was the problem.
Maybe some technical issue because we have been talking with him. Irfan? Yeah, Irfan, can you hear us?
Now I think
now we can hear you.
Right.
Okay.
Sorry, I missed that.
Okay. So let me give the idea of today's program. It will be a 1 hour session. And first there will be a presentation. And then Dr. Irfan will make a practical demonstration of live case contouring. And we request all the participants to put their question in the chat box. And we will compile the questions and then we will be bringing it in the discussion at the end of the session. So in breast cancer contouring, we know that this is a unique scenario where we always mostly we do adjuvant radiotherapy, so there is no pathology. Normally we treat the normal anatomy, mostly post-operative. So this is something different than other because somewhere we need to address the pathology. Here we don't address that. So somebody make an argument, do we really need to do a contouring? And if we do contouring, there are guidelines, what are the pros and cons? And are we aware that what is the outcome of all the guidelines that we have been following? And then the million-dollar question, which guideline to follow? And finally, the everyday challenge, what should I do? Shall I follow the guideline or shall I follow the my training experience? Which one to prefer? So as I had discussion with Irfan, he will try to address all these points in his presentation. And there's a special announcement for today's session that at the end of today's session, we'll provide a link to all the participants who are interested. They can download the data set of the case that Irfan will be showing today. And they will be given a 1 week time to contour the cases following today's lecture and then upload it. And all the submitted case will be evaluated by Irfan and his team. And whoever will be identified as the best performer will be awarded to go to Rajiv Gandhi in Delhi to stay with him for a week and have fun. So beside that, all the follow-up cases, submitted cases in a follow-up session within 2 to 3 weeks time, we will have a follow-up session where Irfan will discuss all the submitted contouring and he will try to discuss what was the limitation he feels was or what was missing on what could be done to improve the contouring. And all the interested participants again will be allowed to have a free discussion to share with him their challenges in every day. So with these few words, I want to stop here and I would like to request our today's faculty, Dr. Irfan, to start. And today we are so happy that beside Irfan, we have friends from Rajiv Gandhi joining us. Welcome you people to, we are so happy that you have joined and it has enriched our session. So over to you, Irfan, you can share your screen and start the presentation.
Yes, sir. Thank you very much, sir. So I hope everybody can see.
Yes, we can see you.
So good afternoon, everyone. It is my privilege to present this session on target delineation guidelines in breast cancer. I'm extremely indebted to Dr. Kamaluddin for considering me for this session. I'm also overjoyed that Dr. Kundan is also here. He is, in all sense of words, a guru, which is a Hindi word for, or Urdu word for mentor, teacher, and it is under his guidance that perhaps whatever little that we have been able to do, I have been able to do, he's guided me towards that. So I'm a consultant under Dr. Kundan in the thoracic and breast radiation oncology unit at Rajiv Gandhi Cancer Hospital. And I would just like to start off this session by saying that this is a disclaimer. Everything that I'm going to talk about, there is absolutely, let's say there are no standards for how these contouring guidelines that we're going to discuss have been developed. In a very interesting systematic review of contouring guidelines in radiation oncology, with time, the number of contouring guidelines has definitely increased, and the distribution is predominantly, let's say, head and neck, gynecology, and GI. But more, perhaps, I would say disappointingly, only 50% of these guidelines actually perform the literature review before actually, publishing their guideline. And even if the guidelines are developed by consensus, only 22% had a certain minimum number of panelists so that the guideline could actually be adopted more widely. And even more disappointingly, only about 15% or so actually provided a full image data. So instead of saying that tomorrow, if Dr. Kundan, Dr. Kamal, and I, and a couple of other experts get together and we'd have a discussion, by day after tomorrow, we can have a guideline. And we can say that this is an Asian guideline for India and Bangladesh and these neighboring regions, and this is what we should all follow. This is actually not how guidelines are actually developed. Right. So obviously, we all would like to know why is there a need for delineation guideline in the first place? We all want to reduce our variations. We all want to prevent a geographic miss, and we all want to minimize organs at risks, doses. And the only way to do that is to standardize what we are doing. But unfortunately, as you can probably see, this is what what our residents actually drew as the level 4 nodal level. So there's actually, I suppose this comes with practice, but more importantly, what you do today will also have an implication of what happens in the future. So what we decide to do today in terms of contouring, let's say the SCF, will still miss some disease. So is it actually necessary to include as much as possible, be as maximal as possible, include everything that you want, so that you don't miss absolutely anything? I don't think that is that should be the goal of contouring. The goal of contouring actually should be to reduce the OAR doses by standardizing treatment and establishing planning priorities. In left breast cancer, which is ostensibly in today's day and age a curable disease, we don't want patients coming after 10 years who are actually expected to live that long coming back with radiation-induced heart disease. So we have to establish planning priorities. And the only way that we will do that is by undergoing rigorous peer review of our contouring, establishing a fine line between over-contouring and under-contouring. Under-contouring to reduce OAR doses and over-contouring to reduce recurrences. And let me just say from the outset, everything that we're going to talk about, at the end of it, I don't want you to come away thinking that there is a perfect guideline for every situation. There's actually no guideline which is applicable for all situations. It has to be adapted and individualized for each patient. And why do I say that? Because most of the evidence that we have when it comes to contouring guidelines, actually started in the 2D era. And this is probably the time when, all the major big name trials from the National Surgical Adjuvant Breast Project came out, but all of them used conventional treatment planning. And with time, as they accrued more follow-up, they found that, it was difficult to translate that two-dimensional information into the three-dimensional era. None of these trials use IMRT or VMAT or any of the techniques that we use today. And therefore, perhaps in 2004, the first guideline by Dr. Ivesa was actually the first one to highlight how treatment planning by raising the arms actually affects the lymph node regions that we treat in patients. So she actually took cadavers and sliced them, and studied the lymph nodal distribution and correlated them with the CT scans and MRIs. And subsequently, there were several other guidelines as well, but two predominantly different philosophies of contouring guidelines developed. The first one was the RTOG guidelines. The purpose of the RTOG guidelines was actually to translate the two-dimensional information from the trials that occurred in the 80s and 90s and became more like a landmark-based guideline. The purpose of them was to cover all those regions in those trials that were covered as maximally as possible. And then in 2016, with the RADCOM guidelines, which were an evolution of the RTOG guidelines, they were still, unfortunately, landmark-based, but they recognized and they did something which none of the other guidelines probably did, was add another volume, which is the posterior neck. And we will come to that and discuss why that is important. The other philosophical shift of guidelines, or rather the philosophical evolution of guidelines, occurred in Europe, where their predominant focus was reducing our doses and minimizing volumes. And the way to do that was to actually follow something which we all understand, that lymph nodes occur or travel along with vessels. So these guidelines were actually vessel-based. Predominantly the PROCAP guidelines and the ISTRO guidelines. They're very similar. To the audience that is going to go back after this presentation, I would suggest that they read the PROCAP guidelines first, because the ISTRO guidelines, as far as the lymph nodes are concerned, is a little confusing, but the PROCAP guidelines are actually very, very simple to understand. And hopefully with some anatomy that I'll show in the subsequent slides, you'll be able to go back and apply them in your practice, hopefully soon. Next, the outline for this presentation. So we'll go through the guidelines for whole breast chest wall irradiation. We'll go through the guidelines for regional nodal irradiation, and I'll try to practically demonstrate the guidelines on our planning system. But I'm not going to teach you borders. I'm not going to teach you this is the medial border, this is the lateral border, this is where you should stop your contouring anteriorly, this is where you should stop your contouring inferiorly. That is all in the literature. And I've also shared with Dr. Vedol a very nice comparative table of these guidelines. About 85% of the borders on both the ISTRO and the RTOG guidelines are same. There's minimal difference in both of them. However, what I intend to actually do in this part of the presentation is to actually show you why these guidelines include or exclude certain regions or areas. And without further ado, let's go ahead with that. So in whole breast and chest wall irradiation, the most important question, which I think Dr. Kamal also said, is that do we actually need to delineate what we already know how to irradiate? We all know that tangential RT fields is the cornerstone of whole breast and chest wall irradiation. So why do we need guidelines to tell us what we need to treat? Because with the modern CT-based planning, the issues of those inhomogeneity which were present in the two-dimensional era have largely been overcome with a combination of three-dimensional planning and MLCs. But there are still some issues here. And the issues which remain are that whether the true chest wall, and by true chest wall I mean the ribs and intercostal muscles, do they need to be included in the target? And what are the implications of including them on the heart mean dose, which is a prime concern. And finally, this may seem like an odd question, for post-mastectomy radiotherapy, everybody uses a bolus, but should we actually routinely use a bolus? These are some questions that we will go through. So coming to the true chest wall, should it be included in our volumes? So this is a standard diagram: skin, subcutaneous tissue, the pectoralis major, the pectoralis minor, the ribs, and the intercostal muscles. And in a very interesting systematic review by Orit Kaider Pearson, in which they found about 6,901 patients in their own data set, they found that there were only about 6 lesions, that's 0.09% of this entire data set, actually had a local recurrence in the ribs and intercostal muscles. 0.09%. You can round that up, it becomes 0.1%. That's about 1 in 1,000 patients. And everything else was anterior to this. Still low, about let's say 4% to about 1%, but 0.1%. Think about that number. And now let's see what this study from Sushil Beriwal's group actually did. So they also analyzed, and they did a dosimetry analysis as well, by reducing the posterior border of their chest wall volume. This is where the estro is, which is in front of the pectoralis major muscle. This is where the RTOG is, behind the ribs and the chest wall. And this is what they did. They just cropped this volume away from the true chest wall. And what they found was that even in their data set, 65% of local recurrences were within this region in the estro. 100% local recurrences were within this modified posterior border. And they used field and field planning technique, and they actually found that their heart mean dose is reduced by about 2 gray here by just, here. So by reducing their posterior border from behind the ribs to in front of the ribs. And they also reduced their lung. So for something which is exceedingly rare, 0.1% of patients are going to develop a chest wall recurrence in the ribs and the intercostal muscles. But all of them, 99.9% of patients, are going to benefit by reducing the heart dose by about 2 gray. So that is one thing we should think about. And that study was performed in post-mastectomy patients. And this is the study that Dr. Kundan and my physicist, Mr. C.P. Bhatt, I'm not sure if he's joined yet or not, and I performed. And our central question was that because the tangent irradiation that we use on a day-to-day basis, and the RTOG, which actually includes the ribs and chest wall, and the estro, which is above all of this, we planned these 3 techniques on 10 patients, and we performed them, and our physicists created 90 plans in 10 patients for field and field, IMRT, and VMAT, which is, I suppose, all the rage these days. VMAT, everybody wants to do VMAT. And our question was in 2 steps. The first question that we was that if we decide that we want to follow a particular guideline, whether it's RTOG, estro, or tangent, is there an optimal planning technique? Is there one technique which should be favored over the other? And what we found was that if you're using the tangent, the standard tangent planning, or the estro planning, there really is nothing between, to differentiate between the field and field plan and the inverse IMRT plan, either here or here. That's because philosophically, the chest wall or the breast that the estro guidelines say that should be treated, they clearly state that it should not be any more than what you normally treat when you were treating with tangent guidelines. And when you talk about the RTOG guideline, it almost seems as if there is no difference, but inverse IMRT was better in field and field and VMAT. This is what we found. Importantly though, what is the influence on heart doses? what we found was that with tangent and with Estro, again, there's nothing to choose between the feel and feel and the IMRT plan, either here or here. And when we use VMAT with tangent plans or we use VMAT with Estro, actually significantly less score. So in this case, higher scores are better, and it received less score. And the other question that we also asked was that in the same planning, the same exercise, we also decided that let's say you are restrained by the technique that you have. Let's say you don't have VMAT, or let's say you don't have inverse IMRT, you only have forward IMRT or field and field technique. So if your technique is decided, is there any target delineation guideline which is optimal for the type of planning that your center is capable of doing? And again, we found that whether it's field and field, whether it's inverse IMRT, the RTOG guideline in totality, when you combine the scores for all the structures that you need to treat, you establish your planning priorities, it's actually scored much less compared to the Estro or the tangential or the tangent delineation. And it seems as if the only place where the RTOG guidelines was actually doing was when you have VMAT. So for all the people who want to practice VMAT every day, RTOG is good enough for them. But if you don't have that, you can actually, if you only have field and field in your organization, you can feel pretty happy saying that our plans are probably going to be superior than the RTOG plans in pretty much all aspects. And the same with the hard dose. Field and field technique, the RTOG technique or the RTOG delineation guideline is actually quite inferior compared to Estro and the tangent guidelines. So should the true chest wall be treated? They are extremely rare. There are no reliable predictors. There are only 6 cases that I could find in the extensive literature review which identified recurrences in the ribs and intercostal muscles. Should definitely be excluded in patients who are undergoing post-breast conservation surgery, adjuvant radiation. Should also strongly consider excluding them in patients who have undergone a mastectomy. And they've also been adopted by the RADCOM guidelines, which are an evolution of the RTOG guidelines. And it definitely reduces hard doses. So you should strongly consider cropping away the ribs and chest wall from whatever planning technique or delineation technique that you're doing. Just remove your CTV away from the ribs and chest wall. The other question is, and this was a question which has probably sounded a little controversial to everyone, including Dr. Kundan when I discussed with him, Dr. Kamal when I discussed with him, was that should we actually be using a bolus for our patients? We know that what we want is written in the textbook, that a brisk reaction should develop by the use of bolus for patients who are undergoing post-mastectomy radiotherapy. But you increase the rates of grade 2-3 toxicities. You increase the interruption frequency from 6 to 38%. The number of days the patients actually interrupted because of bolus placement is about 14 days compared to 5 days. And whether you use your bolus alternate day or daily, your skin grade 3 reactions increase in a pretty linear fashion. And overall, the local recurrences in patients who had interruptions versus no interruptions in this extensive systematic review was about 17% versus about 4%. And the reason why that is because there's an internal consistency in these guidelines. The Estro, in their wisdom, suggests that you should crop your chest wall target from the skin by about 3 to 5 millimeters. And the RTOG also, but the RTOG says that you should keep it on the surface to ensure that your planning or your planner knows that the skin is a target and therefore the full dose should be delivered here. But in an institutional analysis, again, by the same group, in their own subset, in their own data set, in about 1,800 patients, 83% with bolus and 17 without, there was no difference in 10 years local recurrences. Though these curves appear separate, but these confidence intervals are overlapping, the results are not significant. And then, in a systematic review of 7 studies, including about 3,200 patients, the odds ratio for local recurrence was not different between patients who were receiving bolus versus the patients who were not receiving bolus. And why do I say choosing wisely? with the use of bolus in post-mastectomy radiotherapy is because the overall local recurrence rate after most post-mastectomy radiotherapy in the tissue anterior to the pectorals is highest there, and yet the toxicities there actually lead to a higher local recurrence rate compared to the intrinsic probability of a local recurrence on its own based on biology. And unless features associated with skin recurrences are present, skin actually need a full dose. So most institutions that follow the bolus protocol for post-mastectomy radiotherapy, for 50% of the fractions they place the bolus. That is also something that we used to do. But then, does that make sense? If the skin is the target, and you want to treat the skin, it's a binary choice. Either you can choose to treat the skin or you cannot choose to treat the skin. You can't have it both ways, that you have to give only 50% of the sessions a bolus and the rest are not. And unless features which are associated with skin recurrence are present, specifically clinical or pathological skin invasion, dermal lymphovascular invasion, positive margins, especially anteriorly, I don't think we need to treat the skin. And in these particular scenarios for post-mastectomy radiotherapy, inverse planning techniques actually have an inherent advantage. That is because the variable beam angles associated with these inverse planning techniques can drive dose into the skin. So you get better looking plans, but do you actually need that much complexity in your planning? And just adding a 3 millimeter bolus to a tangential plan achieves a similar skin dose compared to VMAT. So the practice of alternate day bolus should also be changed, because like I said, it's a binary choice. If the skin is at risk, it's at risk. You should treat it all days. If not, just don't put a bolus. And this actually led to this guideline being developed, again by Orit Kaida Pearson, and in which a multinational panel of experts, 3 rounds of surveys, and the consensus indications for bolus use are skin invasion starting from T4B all the way to inflammatory breast cancer, post-neoadjuvant YPT4, any invasive or pre-invasive cancer with a positive anterior margin, especially in front of the lesion on the skin. If there is a margin positive here, you should consider using a bolus. Or if you're dealing with a chest wall recurrence or an inoperable or fungating mass. And the consensus statements, I would just like to emphasize that they sort of emphasize that bolus increases toxicity, should not be considered routinely used for all patients of post-mastectomy radiotherapy, and there is insufficient evidence to support that the use of bolus increases local control. Whether it decreases or not, we are not going into that yet, and therefore I strongly feel that the way that we have always done it probably needs to change. And this is the argument that I know everybody will have, that that's the way we've always done it, but we need to change. The next, coming to the probably more controversial or rather more involved part of the discussion, which is regional nodal irradiation. And again, there are some fundamental principles while you read these guidelines, keep that in mind. One is that all of these guidelines were intended for use in the absence of gross nodal disease. So an elective situation, not a definitive situation. The second, if you look at the studies which have explored the location of gross nodal disease and which contouring guideline actually covered which level better than the other, there is a flaw in the assumption there, which is you are assuming like head and neck cancer, where all of the patients are treated with definitive concurrent chemoradiation up front. You're confusing the fact that in breast cancer, where you find gross disease before the patient undergoes surgery or the patient undergoes neoadjuvant chemotherapy, that exact place is where the recurrences will develop. That is the first assumption flaw. It appears, therefore, that we need to understand where the recurrent nodes occur after radiation and try to reduce the rate of recurrence there. And there is certainly a difference between the way nodal recurrences are different, or the distribution of nodes in the recurrent setting is different compared to the distribution of nodes in the upfront setting. However, there is again a flaw in this assumption as well. Because you're assuming that the places where the recurrent nodes are present, those places had microscopic disease when you gave them radiation, and you didn't cover them. And those are the regions where the disease will develop. It absolutely ignores the fact that there is a biology behind breast cancer. There is an aggressive biology, there's a less aggressive biology, and we don't know whether it's bad biology, bad technique, and whether we need to change. And interestingly, all of the studies that I'm going to show you in the next couple of slides, none of these studies had actually contoured the nodal volume. They had treated all of their patients using three-dimensional techniques. And just looking at this diagram and the dose distribution here, if this is where we intended to treat, but you use a 3D planning technique, you're actually going to cover a lot of the regions where nodal recurrences actually occur. So it's not as if not covering this region is going to increase your rate of recurrence, because it's already received some amount of dose. And when reviewing the literature on nodal recurrences, that is why very careful attention needs to be placed on the type of technique of radiation that they used. It is also extremely unlikely that there will be a comparison between the RTOG and the ISTRO guidelines. Just a study of that magnitude probably will never be performed because of the difference in philosophy. And lastly, all of these guidelines, like I said, whether it's the ISTRO or the RTOG, none of them actually had, data sets of nodal recurrence patterns, and they were based on expert opinion. And they didn't incorporate these findings, except one, which I will tell you. So this is just a slide. We're going to show you, what is the nodal involvement in the upfront setting versus the recurrent setting. And this is a study performed by Baum. He took 235 PET CT scans. Details of radiation were not reported. That is why I'm going to keep this a little separate. And they compared the ISTRO and the RTOG lymph nodal coverage. So if you can probably see here, in the upfront metastatic setting, upfront non-metastatic setting, the predominant burden of disease appears to be in the axilla. Very few in the supraclavicular fossa, very few in the internal mammary chain. But in the recurrent non-metastatic setting, besides the involvement in the axilla, there's also significant involvement in the supraclavicular fossa, significant involvement in the internal mammary chain. And this distribution is actually different for both these situations, whereas in the upfront setting, about, let's say, 90% of the nodes were present in the level 1, 2, and 3. In the recurrent non-metastatic setting, about 20%, up from about 8%, occurred in the supraclavicular fossa and the internal mammary chain. And on comparing these guidelines, RTOG is in red, ISTRO is in gray. The percentage of nodes outside all of these individual levels was probably the most disparate or disparate in the supraclavicular fossa. About 36% of nodes in both these data sets was outside the ISTRO guideline. So we, Dr. Kundan and I, we actually decided that there's no point just telling you what all these individual studies are. Let's just pool them together. And we performed this analysis. We found about 4 studies, 585 patients, and 765 lymph nodes. And they were both classified separately. I'll tell you why. Because this compared RTOG, ISTRO, and RADCOM guidelines. This is a study by Beaton. And 3 studies comprising the majority of these compared ISTRO and RTOG guidelines. And if you look at the overall pool incidence of recurrent nodes inside the ISTRO CTV compared to the RTOG CTV, the combined probability that recurrent nodes will be, or rather let's say the odds ratio of the ISTRO CTV, if it's less, it means it's worse. So it's not significant. So it is trending towards the perhaps inferior compared to the RTOG CTV. But the result is not significant to pooling all of these 4 studies. But when we look at the same analysis, specifically only for the SCF, the supraclavicular fossa. And here we find clearly that the ISTRO CTV is somewhat inferior because the probability that a recurrent node will be inside the Eastro CTV is less compared to the RTOG SCF is significant. And that is probably because the RTOG SCF is actually slightly bigger compared to the Eastro level 4. And in this analysis, all of these studies, they also did this analysis, in which they figured out, compared to within Eastro, which is about 64%, 71%, about 21% in all of these 4 studies, if you actually increase your CTV to the RTOG SCF, how much more nodes can you actually cover up? But surprisingly, this is only in at least 3 studies, it's less than 10%. So that probably means that we are missing something. There is some region that this is not covered by both the RTOG and the Eastro CTVs for the SCF. And that area appears to be in the posterolateral triangle. And when I say the posterolateral triangle, this is where the RTOG contour for these 3 levels are. These small dots are where the recurrences have occurred. And whether you look at it from a 2-dimensional point of view or a 3-dimensional point of view, you will find these red dots, they are actually outside this blue line, which is the RTOG SCF, and this purple contour, which is the Eastro SCF. And this area is actually known as now, in the RADCOM guidelines, the posterolateral SCF. And this is a region which is a new volume. This has been added to the RADCOM, like I said, as a posterior neck CTV. And however, it is understood that a lot of these recurrences occur in this triangle, the posterolateral triangle. But what are the factors associated with recurrence in this region? We're not sure. It's still unclear. And probably the ones that these 4 studies have identified is that patients who are young, triple negative, who have extensive lymphovascular invasion, extranodal extension, and are grade 3 tumors. Probably these patients are the most predisposed to recurrences in this region. And though the RADCOM guidelines has said that, this is a new volume, they have not given any indications for how this should be treated. And but interestingly, in the last study that I mentioned, the Beaton study, in which addition of the RTOG guideline to the Eastro only improved the recurrent node coverage by about 9%. If you include the RADCOM posterior neck and they analyze it separately, you've covered an additional 32%, leaving only about 20% lymphatics or scarring or other such changes. And this is 2 or 3 more slides. I'm sorry if I'm taking this, if it's taking too long. This is probably important to understand because with early breast cancer, the study by Baum, which I showed you initially about non-metastatic recurrent setting and upfront setting, they took all those notes and they planned radiotherapy according to the 3 guidelines in early breast cancer, which demonstrated evidence of regional nodal irradiation, and also the Z00011 trial, in which there was no regional nodal irradiation, and they registered both of these planning techniques to 3 women of varying builds. And this is the coverage of the Eastro level 4 dose volume histogram, and this is the dose nodal histogram, basically showing that the dose that these regions in the level 4, how many percentage of nodes were recovered in level 4. They did this analysis for all the levels, and I just want you to have a look at this line. So they prescribe 50 gray in all of these planning techniques. 95% dose received by only about 50% of this level 4. And again, 95% of the dose covered by only 50% of nodes. But despite lower doses in the SCF and as well as in the other nodal regions, in all of these trials, both the EORTC and the MA20 trials showed a clear benefit with regional nodal irradiation. So, and it is also likely, based on this analysis, that these randomized trials likely didn't provide full dose coverage to all the possible locations of lymph nodes, but they showed a clear benefit. So that probably leads us to conclude that extensive target volumes are probably not necessary to reproduce the benefits shown in these trials. If you have an early breast cancer patient and you want to cover all of the regions where they probably may have a nodal recurrence, that is probably not the best idea, because based on this, that you will be adding a lot of toxicity. The second study that I would like to show you, and this I'm sure Dr. Kamal would be very happy to see, is because this group by Kowalski, they took 389 lymph nodes in their breast cancer, and they did 3D conformal planning using bony landmarks. And they contoured the estro RTOG in the RADCOM CTV, and they planned using VMAT and Proton. So, and this is just a representative slide of the dose distributions. Standard 3D, VMAT, and protons. Beautiful dose distribution with protons. I would love to have this for a patient. But what was their objective? Their objective was to see the coverage of lymph nodes by the 95% isodose line. And these lines in green, I'll just quickly go through them. The 3D conformal plan based on bony landmarks covered 97% of all lymph nodes in this particular planning atlas. Comparable to VMAT, comparable to Proton, and definitely better than the combination of RTOG, estro, all of these, but at the expense of a very high heart mean dose and a very high left lung V20. So when I showed this to Dr. Kundan, I was like, look at this, we should just be doing 3D. But what he said was that to achieve this with a 3D plan, you probably would have to increase the volume of your 3D planning to a lot more, and have a lot more uncertainty. And therefore, this probably means that with a appropriate attention to target delineation, doesn't have to be extensive target volume, doesn't have to be very sophisticated treatment planning. You can probably cover all of these regions very well if we follow certain planning priorities and institutional guidelines. And this is where this is the penultimate slide. This is taken from a paper by, this is a very tricky name, Logan Dane. Their group actually compared all the nodal target volumes, and this is a combination of this paper and again Orit Kaida Pearson. So we need to define what our regional risk is. If it's low, and by low it probably means patients who are clinically T1 and T2, clinically node negative, and they undergo a breast conservation surgery, either with a sentinel lymph node biopsy alone or an axillary lymph node dissection. And they turn out to be pathological T1, T2 as well, hormone receptor positive, and a pathological node 0 or node 1. I think we can get away with the estro guidelines, because the estro guidelines are a little conservative. They have smaller volumes, and they therefore reduce the probability of other complications like hypothyroidism, heart disease, etc. If your regional risk is, let's say, high, these are clinically T3, T4 patients with node N1 or N2, they either undergo neoadjuvant chemo or they undergo mastectomy up front, and they turn out to be pathological N2, N3 after MRM, or pathological T3, T4 after MRM, or they have residual primary disease, residual nodal disease after neoadjuvant chemotherapy. Let's say they also have triple negative biology and they are young. I still feel that we could get away with estro if we give 1 to 2 centimeter margin or on the pre-op or pre-chemo imaging of the node positive locations. However, you could be very well justified using the RTG or the RADCOM guidelines, but without the posterior neck in both of them, but still using the internal mammary nodal guideline as per the estro and the RADCOM guideline. And for patients with very high regional risk, these are patients with gross internal mammary nodes or gross supraclavicular fossa nodes. Patients with gross internal mammary or gross supraclavicular fossa nodes should probably be treated with RTOG and RADCOM guidelines. If there's gross SCF, they should also probably have a posterior neck volume. For the RTOG guideline, again, use the internal mammary chain as per the estro and RADCOM, and probably also consider the RADCOM posterior neck patients with gross internal mammary nodes. And I would like to thank, my my senior, my mentor, Dr. Kundan, who's with us, Dr. Rahul, who's an attending consultant, Dr. Mohammed Ismail, who is our senior resident, and Mr. C.P. Bhatt, who is a chief physicist at where we all used to work previously, and also was kind enough to provide the data set, anonymized data set for the contouring guideline, which I'm about to show. So thank you for your attention. Before we switch on to the delineation guidelines, are there any questions?
So, thank you, Irfan. I think, as we said, we'll be keeping the question for the later on. We can move to the contouring, but in the meantime, if Dr. Kundan want to make a quick comments, I'd love to hear from him. Kundan.
Not really, but I think Dr. Irfan has covered very nicely actually all the aspect here. So the only point here was I just put it in the chat box also. So like for early breast cancer, as with low risk as well as with high risk, what we actually treat is an undissected axilla. So we don't have to treat a level 1 and 2, which usually anyhow most major part of it comes in your tangential fields. So that's one thing I just want to add on that. Whenever we are taking the undissected axilla, usually identified by the clips which the surgeon keeps there along the vessels, at the higher edge of their dissected axilla.
Thank you, Dr. Kundan. That is very important because not to chase the axilla, dissected axilla chasing will increase the volume unnecessary and will increase the OAR dose. So thank you. Now I think we can move to this contouring thing, Irfan.
Yes, sir. So that's something that I actually forgot to put. Chasing axilla 1 and axilla 2 in most situations is probably not, like Dr. Kundan said, should usually not be done. If we have to treat, especially if it's early breast cancer or it's even high risk in which there is, let's say T3, T4, the SCF undissected axilla and the internal mammary chain is probably going to be sufficient. So now going on to this, so I actually didn't know how to show the exact contouring guidelines for both of these. So I've just pre-contoured all of these structures. First of all, I just want to show you in 3D if possible. Just a second. So I'm just going to turn on the vasculature and I'm going to turn on the body of this patient. Thank you, Mr. C.P. Bhatt, for this data set. So this is pretty much all the vessels that you need to know. It's probably also not important that you know their names. Let me just be very frank in saying that. And I'll tell you why. Because in this particular patient, the reason why I chose this patient was because this patient had a skin infection and she had non-pathologically involved nodes. So as you can see, I have a structure here by the name of GTV nodes. And these are all non-FDG avid inflammatory nodes. They all have a fatty hilum, but you can pretty much see that a lot of these nodes are just running around the vasculature. Pretty much quite a significant number of that. And the reason why that's important to know is because from the surgeon's perspective, when he's doing an axillary lymph node dissection, what exactly is he doing? So I'll just recreate that for you. He has placed the patient with the arms abducted like this, and he has entered this patient's axilla in this particular direction, right? And if we scroll this, I just want you to focus on this particular region. If he's entered the axilla now, and you can see that the axilla is mounted by the pectoral muscles anteriorly and the lats posteriorly. And if you I'm just going to turn on, irrespective of what guideline that you use, if we just turn on all the lymph nodal levels, and the surgeon is now entering the axilla. These are the distribution of nodes that he will see, and he will continue to contour them till the time that he cannot find any space between the pectoral muscles and the vessels. Basically, I'll just also turn on the vessels. till the time that he cannot find any space between the vessels and the nodes. Of course, preserving the nerves, etc. I'm not trying to trivialize the job of a surgeon, but this is what he has to do. And the place where he or she usually stops dissection is anterior to the pectoral muscles, the minor pectoral muscle, this region. And this region is what we know as the level 3 axilla in pink here. So that is the first thing. The second thing I wanted to turn on and show is when we're contouring and we're looking at the guidelines and we're figuring out this is level 1, this is level 2, this is level 3, it's probably important or easier to think of level 1 and level 2 as one group, because irradiating them is done in certain infrequent situations. And contouring level 3, which is the infraclavicular fossa and the supraclavicular fossa and the internal mammary chain. The level 3 SCF and IMC are usually treated and contoured in a different situation, probably mostly in all patients who are going to undergo regional oral irradiation. So I have a very handy list here. I've shared that with Dr. Tohidul. But let's start with level 4. The easiest way of understanding contouring for the neck levels is by doing level 4 first and going retrograde. So the boundaries of the level 4, the main differences, or rather the main vessels that you need to identify are these. Starting from the arch of aorta, you need to identify these 3 vessels. This is the subclavian artery, this is the left carotid artery, and this is the right brachiocephalic artery. As we go up, the reason why the subclavian artery is important is because it forms this arc that you can see here. This one. And this continues after it passes through the thoracic inlet and becomes the axillary artery and then carries on as the artery of the arm. The second important vascular structure from this particular region that you need to identify is the vein. So this is the axillary vein. I'll have to rotate this a little bit. Just a second. This is the axillary vein, and this joins your internal jugular vein to form the brachiocephalic vein. And identifying this is important because the artery and the vein in this particular region define the cranial and caudal border of the istro-SCF. So if we look at the istro-SCF, its cranial border is going to be the place where this arch here, its most cranial edge, which is here, and one more slice, so roughly about here. It importantly excludes the internal carotid artery from this CTV. Just highlight this here. It excludes this region. This is the scalene muscle. So this scalene muscle originates from the neck and inserts onto the first rib here. I looked at the guidelines. Some of the guidelines that have been published, they actually include the scalene muscle in their CTV. But it does not make sense to me to include a muscle in the CTV when it is the vasculature that we are more concerned about. The inferior border, as defined by the istro, is about 5 millimeter below this region where the internal jugular vein combines with the axillary vein. So if I can say that this is where that use is happening, about 1, 2, 3, these are 2 millimeter slices, about 5 millimeter below, this is where my estro level 4 STF is going to stop. Anteriorly, it is going to be the clavicle. Posteriorly, as I mentioned, you can either include the scalene muscle or not. And laterally, it is going to be, let's look at the notes here. Laterally, it is going to be at the edge of the scalene muscle. The reason why I have to look at these notes is because after you do about 3 or 4 cases, 5, maybe 10 cases, this will become muscle memory for you. You will not have to think about where I need to start and when I need to stop, because you will continue with the contouring of the level 4 along with the contouring of the level 3. Now the level 3, which is the region, lateral to the clavicle or the infraclavicular region, the undissected axilla in most scenarios, its medial border is the lateral border of the STF. So clinically, when you're doing this contouring, you will just contour the STF, carry on in this region, and take the pectoralis minor muscles medial edge as the lateral edge here. And then you will go forward, exclude the pectoralis major muscle, cover this fossa, and be done with it. The place where you have to start and stop cranially and caudally. Cranially, you have to pretty much start where you're starting your level 4, and inferiorly, you have to stop again, like I said, either where the surgical axillary lymph node dissection has been done, or even further caudally, just including this space till you cannot see it anymore. The medial and lateral borders, like I said, medial connects with these STF. The lateral border is going to be the medial edge of the pectoralis minor muscle here. Posteriorly, so the reason why I also drew the vessels in this particular case was because if you just draw these vessels, the axillary artery, the axillary vein, and you just give them a 5 millimeter margin. This will also tell you where your posterior edge for your level 3 as we go along level 2, level 1 should be. It is not always very obvious where some of the landmarks that they have mentioned in the guidelines are actually present. So this is a nice safety margin. So I mean, at least your CTV should be, in this particular case it's not, but at least your CTV should be around here, which is a 5 millimeter margin on the vessels that you have just contoured. And now, at this point, I'll just take a break. Take a break in the sense that I will not continue on with the ISTRO guidelines. I'll show you how the RTOG level 4 guidelines are different compared to the ISTRO SCF guidelines. So the RTOG guidelines are more generous. As you can see, the cranial edge is at the bottom of the cricoid cartilage, which is somewhere around here. And we start contouring, and you include the vein, you include the artery, and you continue contouring laterally up to the supraclavicular or the sternocleidomastoid muscle's lateral edge, and continue contouring till you reach the clavicle. And this is where so there's sort of like a internal discrepancy in this guideline, because I remember, I'm sorry I'm digressing, but I remember when I first contoured using the RTOG guideline, I couldn't understand why there is a gap between the STF here and the ISTRO level 3 here. Why are these two disconnected? I couldn't understand. Even here, if you see, let's turn off the ISTRO. These two are disconnected. And when I first did this, I couldn't understand this. So I asked Dr. Kundan, I asked our physicist, and the answer that I got was that ignore that. You have to connect these two volumes. So in practice, where there is a natural border, for example, here, this is, a muscle, I cannot identify it, I'm sorry. But where there's a natural barrier, probably these two CTV should not be connected. But ideally, they should be. So your actual RTOG CTV connecting the level SCF and the level 3 should actually be something like actually connect them like this, and these two should be a combined volume, and you should continue doing this wherever you can connect them, and do this. Why these guidelines say that there should be a gap between these two regions, I don't know. But this is what you should be doing in practice, so that there is no untreated space, because eventually this is where the vasculature and the lymphatic channels are going to run. So you just connect them and you are going to be done with this particular volume. Inferiorly, coming back to the RTOG SCF guidelines, inferiorly, again, this is where the ISTRO and the SCF guidelines are different. The ISTRO guidelines are actually a lot more caudal, because they take this junction and 5 millimeter below it as the lower border of the ISTRO guideline. But the RTOG guidelines just say that you should just stop here, where these vessels are getting joined. So that is as RTOG SCF. I would love to hear some feedback on how I'm doing. I would like to know if there's anything that you want me to see. Please feel free to interrupt me. I don't have a plan for this, how I'm doing this.
So I think we can continue, Irfan.
Right, sir. So the reason why this discrepancy between the RTOG and SCF guidelines is also important is because if you look at this, probably it will be better shown. So this is where the RTOG SCF is, and the RTOG internal mammary chain. There is also another gap here, if you can see. Is it visible? I'm sorry, I'm not getting any feedback.
Yeah, it is visible. You can see it fine, clear.
Yeah. So the RTOG SCF, where it stops, it is actually somewhat cranial to where the internal mammary chain is, or the internal mammary vessels are. And in the same region, if you look at the ISTRO guideline actually ends exactly where the internal mammary chain starts. And the main difference in the internal mammary chain is, and if you remember the last slide of my presentation, if you're using the RTOG guideline, you should use the internal mammary contouring guideline of either the ISTRO or the RADCOMP, because the ISTRO guideline for the IMC actually adds a 5 millimeter margin, and also includes most of the recurrences. For example, in this particular patient, there's one node here which is actually here. If you just treat the vessel here, I'll just scroll down to this view. Yeah. So if you just treat this vessel here, probably you will also include this node in your target, but adding this into your CTV is probably a little better, I would say. Then, so that is about the STF and how it's different in, ISTRO and RTOG. The level 3 of the ISTRO and the level 3 of the RTOG, there is very little to choose between them, but there's one major difference, which is that if you look here, the RTOG is in red, the ISTRO is in purple. The RTOG is significantly more cranial and includes a lot more region a lot more tissue in this region, because whereas the estro emphasizes that you should cover the vessels first and whatever area is below the vessels, the RTOG places a lot of emphasis on actually treating this region. And ostensibly, what would happen if you do that? So probably if you combine your RTOG SCF and your RTOG level 4, and you just place, let's say, a field here like this and a field here like this to cover this with about, let's say about a centimeter margin, you would be placing a lot of the humeral head at risk, depending on how lateral you're going, how much you want to treat in this region. You could be placing a lot of dose in the humeral head and the humeral region, leading to a lot of shoulder dysfunction, patients with frozen shoulder. We're seeing a lot of patients, either before surgery or after surgery coming with frozen shoulders. Probably this is the reason why that is. The other difference when you do this sort of planning, again, if let's say you're just treating the SCF, you're not treating the undetected axilla, you're just treating this region, and you're covering this with a field, is that you will be placing a lot of the thyroid also in the path of the beam. This is the thyroid here. You'll be placing a lot of the thyroid, and a lot of the thyroid will, your patient's probably not going to come back to you, probably going to go back to the medical oncologist and having hypothyroidism. And medical oncologists are very fond of saying that, everything that is wrong with the patient is because of radiation therapy. So, we don't want that. The other thing is, that, when you are using the estro guideline for level 4, what is actually going to happen is that your level 4 for the estro is going to be it's actually going to be a lot lower compared to your RTOG guideline. It is going to be here. And here, if you place a restricted sort of field, to cover this region, you're probably not going to irradiate a lot of the thyroid. If your cranial borders are very low, you're going to probably improve the rates of hypothyroidism in follow-up patients. Okay, so we've covered RTOG and estro level 3 and level 4. I'll quickly show you. I think I've already showed you, but I'll just show you how the IMC region looks. So what we usually do is that we contour the vessels. I'll just turn off the contour so that you can probably see them a little better. It's probably easier to identify these two twin structures. I'll just zoom in even more. It's probably easier to identify these two twin structures, not starting from where they originate, which is from the subclavian vein, the vein, internal mammary vein, and the internal mammary artery. It's easier to identify than someplace where there is not a lot of tissue attenuation happening. You can probably identify these two twin structures in the second or third intercostal space and take that as a reference and continue either marking them either as separate structures or just combining them using a 3 millimeter brush and contour them cranially till your lower border of the estro CTV and give them a margin about 5 millimeters and then crop them from the lungs, crop them from going into the ribs, and what you will have is this. This volume will sort of protrude in between the ribs, will come out, but definitely will not go into the lungs and will definitely not go into the ribs. Can go into a little bit of the intercostal muscles, but this will be combined with your breast CTV. So probably don't give that a PTV because that will just increase the amount of tissue that will be going into the lungs. And the physicists will have a very hard time optimizing that region. Coming to probably what I would say is not as important because a lot of us are not treating the axilla level 1 and level 2 these days. But going back to where I showed you where how the surgeon enters this particular region, if we just identify the pectoralis minor muscle and the vessels, give them a 5 millimeter margin, and we look at the istro level 2 CTV, this is fine. This is all you need to do. You just need to figure out where these vessels are crossing into or behind the pectoralis minor, where they're exiting, and this is all the region that you need to treat. There is one difference between the istro and the RTOG in this particular region is because what the RTOG wants you to do is to treat like this. They want you to treat all the way up to the surface of the subscapularis muscle here and the latissimus dorsi here. And they want you to chase this region, this extra region. And they also want you to stop contouring where the vessels cross over. But the istro says that you can probably, if clinically indicated, so like in this case, if I'm dealing with this case and I can see that there are nodes still here in this region, I would continue contouring my istro CTV all the way till the pectoralis minor inserts into the ribs, and there is no space left here. So that is one difference. The other difference is in continuity with this is that, again, when we look at the istro level 1 and the RTOG level 1, turn that off, please. So when we look at the istro level 1, they again don't want you to go first. They don't want you to go, if you contour the humeral head in green here, I give this a 1 centimeter margin. They don't want you to go more lateral than this on each slice as you go down. They don't want you to go more lateral than this. That's because they want to prevent shoulder morbidity. And as you go down, they also don't want you to chase this region in front of the subscapularis and the latissimus dorsi. Why? Because, let me just show you why. This is what RTOG wants to do. They want you to chase this region and fill up all the blanks in between this region wherever you find them. What will happen when you do that is that, let's say at this level, I'm a big believer in tangent. So I'll just place a tangent like this. This is how I would say, let's say, place a tangent around the mid-axillary line here. And I will keep the center, let's say, somewhere near the midline here. This is how I place a tangent. And I ask my physicist, with this particular tangent, I also want to treat this region. And I want to treat with a tangent. What will he do? This? I mean, I don't know if that is how physicists would do it, but this much. And how much of the heart would that include? I'm assuming a lot. How much of the shoulder will this patient's? So it's obvious that the RTOG guideline, if you use them to treat level 1 and level 2 axilla, you are going to require VMAT, you're going to require IMRT, you're probably going to require proton if you have it, and that is just not indicated. On the other hand, if I just use the istro guideline here and turn that here, and I have to just treat this much, probably I can accept some amount of underdosage here. I don't want coverage here most of the times in level 1 and level 2, but I do want it. Probably I can get away with high tangents and be done with it. So, do you also want me to show you the breast CTVs, Dr. Kumar?
Yes, please. I think quickly we have some time.
Right, sir. So for the breast CTV, it's a little, I wouldn't say difficult. I would say it's a little tricky. what you need to identify is vessels. I'll use the normal side vessels first to identify them for you. You need to identify the medial mammary branches of the internal mammary chain, this vessel here. How do you identify this vessel? Because if you look at it from the frontal view, and if you just focus on the lateral edge of your sternum here, you will find these little protuberances or these small vessels which are coming out from the muscle, like forward. And these are your medial edge of your breast CTV. I'll just create a new structure. So looking at this structure here, and what I would do is I will identify this and keep that as my medial border. Laterally, what they want you to identify is this. So if you just place your cursor here, and you use this view, the sagittal view, to identify they want you to identify this particular vessel, which is almost a straight line in the mid-axillary line, and this goes cranially to join both legs. This is the axillary artery. I'm sorry. This is the lateral thoracic artery, which is the lateral border of your estro-CTV, and this is not at all in one plane, but it just follows a straight line in the mid-axillary line. And if you can identify that, you'll find a corresponding structure on the other side as well. And that is how you can probably also confirm that you're looking at the right vessel, because this vessel here is going to just go and join the artery here and continue down here. And all of the breast parenchyma is going to be anterior to this, because this is the vessel which sort of in the diagram that you see in anatomy textbooks are the two main supplies of the breast from the medial and the lateral edge. And everything, all the vessels inside the breast are probably a tributary of these two. So coming back to what we wanted to do, which is just contour the estro-CTV, I'll just figure out a slice where I can see both of these vessels clearly. Yeah, so in this slice, I can see this vessel here. See this structure here. I can see this structure here. And my breast CTV is going to be something like this. We'll keep my medial edge here. Keep ahead of the pectoralis major muscle here. Come back, cover this like this. I'm going to change this obviously, but just for demonstration purposes, this is what I want to treat. And most of the times when I'm doing breast contouring, I just probably copy the same structure, paste it on another slice, adjust it. Now here is something where the seroma is abutting the pectoralis major muscle here. I'm not too sure about the margin here, probably I'll increase it a little bit. Here is that vessel again that I want to keep my posterior border at. And I'll just smoothly transition this out here. And basically that is how I will continue contouring and then interpolate and then make fine adjustments to this. But that is not how I do. Contouring in this particular case. What I actually do first is I place tangents. I place tangents exactly where the medial and lateral border of the estro-CTV should be. And I do that first. I mean, these are hypothetical tangents. I just place this somewhere in the middle of the breast. I place this at the top of where I cannot see any more breast tissue, which is somewhere around here. And I place another tangent here. Somewhat generous, but this is what I would call, what I understand, high tangents. And then I come back and I contour my last slice or place a tangent there. And in this particular case, this would be somewhere here. And then what I do is that I actually just contour these 3 slices. I contour my last slice, which was here. I contour my middle slice, which was somewhere here. And I contour my most cranial slice, which was somewhere here. And shockingly, I just interpolate all these first. And this sort of gives me a rough idea of how my tangents should look. And I usually prefer not to contour anything beyond this. That is CTV at least. Whether you choose to mark your PTV directly like this or not, that is your choice. This is a non-deviate, non-deep inspiration breath hold patient, so there's some amount of heart definitely here. But here in that region, this is where that point of excluding the true chest wall comes into play. If you just sort of, you just exclude the ribs from this region and the chest wall, the intercostal muscles, you will get more space between your heart, the apex of your heart, and your PTV, and your physicist will not tear his head out trying to cover this region if it's actually just abutting the heart here. And if you just carry on and do that in a couple of more slices, you probably will end up with a lower heart dose than if you just include this region. That's the first point that I wanted to make. I don't have an anonymized mastectomy patient, but this is what I would normally also do for mastectomy patients also. And Dr. Kundan would also agree that this is what we are almost doing now. The other thing is this, that if I don't want to do this, let me just create a new structure for RTOG. And let's say it's a T3 breast cancer. The seroma certainly looks like it's a T3. But if I were to treat this using the RTOG guideline, what would I do? I would do this, right? And then just for the sake of demonstration, just copy this for a few more levels. Here the posterior edge just in front of the lats, and the medial edge just lateral to the sternum. And do this for a couple of more slices. Here my posterior edge is significantly ahead, so I'll just cut that out. And it's not complete yet, but I'll just interpolate and show you that placing tangents, like if your physicist is again to sort of plan this patient using these two posterior edges, what would he do? For the east row, he would probably place a tangent here like this. And for the RTOG, he would probably place a tangent like this. Probably. And end up probably irradiating a little bit more of the heart. At least in this slice, it would actually turn out to be like this, but probably end up irradiating more of the heart. In fact, the eastro-CTA will be like this. Right. So I don't know, should I stop or not? But what I can probably say is that these guidelines are not rules. These guidelines are sort of minimum areas that you need to cover to achieve a certain outcome. And I don't feel that there is any guideline that is appropriate for all situations. If in this particular patient with so many gross lymph nodes, if I were to treat this patient, I'd probably not be using the Istro guideline. I'd probably be using some more conformal technique. I'd probably be covering and trying to cover all of these nodes with some additional margins, giving them a CTV and everything. But if this was an early breast cancer patient, known lymph nodes, T1, T2, ER/PR positive, I wouldn't need very fancy or very hi-fi techniques to treat this case. So I'm just going to stop now, sir. I think I've been talking for too long. I feel uncomfortable when I talk too much, and Dr. Kundan said that I have talked too much sometimes. So
thank you, Irfan. I think what we discussed earlier, we could have covered the basic background behind the guidelines, the strength and weakness, and the demonstration that you have done. And as we discussed earlier, that we will be sharing some contoured images with our participants. So we can stop it here because we were supposed to be 1 hour or just 1 hour and 30 minutes. This type of discussion is a never-ending discussion, but we need to stop somewhere. So I think you have fairly covered most of the thing, and for the sake, we had a preparatory discussion. There we decided to keep the argument not to be brought today because for the sake of time. So what I'm going to say that you have brought out the Istro and RTOG issue, choosing wisely, and the Bolus issue is very tempting because changing a long practice is really challenge, but data is convincing that maybe it is high time to bring a change in the Bolus issue and also the chest wall issue. So many of us have been treating breast in many other ways, but we should be following some guidelines and evidence. So that is the message that maybe today we have been having. From our end, Dr. Kundan, would you like to say something?
No, sir. I think we have already covered everything. I think most of the things we have covered, and probably the nicer discussion would be if we get a feedback on the given images, and then probably we should have one more session, and then probably will be a very good discussion at that particular juncture.
Yes, Dr. Kundan, that is exactly what we thought, because today we have served the food, let them eat it, digest it, and then we will have the discussion on the follow-up session. So what were the challenges they faced? Because seeing somebody doing is very easy, but reproducing by the biggest challenge. So when our colleagues will be downloading the data set and doing their own and face the challenge, they will come back with their questions, and definitely we will be discussing. Because say for me also, I have many questions that with the supraclap going such a deep field, how we will be covering, and or he was talking about the thyroid doses and the shoulder. I was scared about the lung doses also. So there are many issues that can be brought about the volumes and how and when to choose what. So I think we can end today.
I wanted to just also invite Mr. Bhatt. I have been talking about him, and he's been listening and not interrupting very nicely. But he is our, Dr. Kundan, Mr. Bhatt. They are responsible for whatever little that I understand. Mr. Bhatt, are you there?
Any comments from you?
Yes, I am.
Sir, good to see you. If you have any comments, sir, please. I made a lot of assumptions about where you place tangents, etc., but that is what you have taught me. And I remember the first time that I gave you a tangent plan, you were like, what is this, Dr. Irfan? What have you made? I cannot do anything with this. So please give us a few minutes of your time and share with us your expertise, sir.
Definitely, as a physicist, what you have to, as per contouring, what you have to, when you are thinking about a plan. So we have now, particularly with advanced technique like VMAT and IMRT. So we started with 3D CRT, where we have a experience of 3D CRT with half beam block, and then we extended that to IMRT with half beam block, then VMAT, then partial VMAT. So that way, definitely, whenever we are discussing about those two OARs and to cover PTV as well as those two OARs, so it's very important to select the planning technique. So definitely, when you will, going through this contouring, then it's important what planning technique should use. So that again will be a challenge to get the cover the PTV as well as spare the critical organs like lung, heart. So those are that again a challenge, with if you are following RTOG, is true or tangential. So how you will manage with dose constraints. So that again will be a challenge, So with this and Dr. Kundan sir, so definitely we learn all these basics from Kundan sir. So thanks to Dr. Kundan sir as well as Dr. Irfan, we as a team started this, and that's a physicist perspective, how you have to go for.
And all the contours that you will send across to me, sir, Dr. Bhatt will be the one who will be doing his planning on all of these contours to show you the implications of each individual contour that your participants send to us. He will create plans for all of those and show you what are the differences between all of these individual plans that created on these individual contours, and how I wouldn't say gold standard, but I would say that my contours would have led to a plan versus everybody else's plans, and see what differences there are.
Thank you, Irfan. I mean, what Dr. Bhatt was telling, that when we are doing the contouring, we should understand what my physicists we will be asking them and what challenge they will be facing. Just doing a contouring and throwing it to them will not be the issue. So I need to know what will be the challenge for them. And end of the day, when we will be sitting together to evaluate the plan, they will put as an option, Dr. Kamal, what do you want? Where or the dose? I mean, then we need to take a call. So this we need to think from the beginning. And we will have 2 more sessions on breast cancer beside this contouring, where we'll be discussing with the techniques and the plan evaluation, where we'll be having more discussion, I believe. So with this, I think today we can end up, and this is a promise from our end that when we will be communicating with all the participants, we will send you the connectivity, where from you can download the image set. We will say how to do it. Then go to your Eclipse, or your planning system and draw the volume. And again, you can upload it to the Google link that I will give. And then it will be sent to, it will be retrieved by Irfan and his team. And we will come back with all the contouring. It is not an exam. It is a fun. We will find out somebody best to take a flight from here to Delhi. And most important, whoever will be participating, we will have the discussion, because nobody is perfect. We will find out what was the challenge faced by the physicist and what was the challenge. So in the contouring time, we can understand if this was the challenge faced by a physicist, I will be cautious about my future contouring. So I would like to request our President, Professor Hai sir, to formally close the session, sir.
Okay, Dr. Kamal, very, very nice discussion this afternoon. My heartfelt thanks to Dr. Irfan, Dr. Kundan and Bhatt. Hope they have taken lots of troubles to enlighten us with this contouring process. Meet again in future. This item has already taken 1 hour, 40 minutes. Thank you very much. So I think we should stop now here.
Sir.
So goodbye, everybody.
Thank you, sir. So thank you, sir. I mean, we want to thank our academic partner, Healthcare Pharma, who has been supporting us. And thanks to our overseas faculty, Irfan, and also the guest, I will say, Dr. Kundan and Mr. Bhatt, and for sparing your holiday. So thanks to all the participants, and see you on the next session. Next session will be on different techniques of radiotherapy used in breast cancer. And we will have another faculty from Rajiv Gandhi. And the faculty is Dr. Parveen Ahlawat, who will be talking on different treatment options, BCT, PMRT, conventional, hyperfractionated, ultra-hyperfractionated radiotherapy in breast cancer. And we hope that this will be a more exciting session. And again, that keep tuned, wait for the link, go to the link, download the image, participate in the session. You don't know, maybe you are the person who will be flying to Rajiv Gandhi. With these few words, thank you very much. See you, stay safe, and stay tuned. Thank you very much.
That's it.